All right. So thank you so much. I think it's just so important to think about how we can empower patients to find community, find support, and also share their experiences. And we're really grateful to you for sharing your experience with us today. So I'm thrilled to be here on behalf of an incredible panel. We're going to take the next hour to really explore how we can expand supportive care options to improve patient experience before, during, and after treatment and in survivorship. Let's see. And just to kick it off, I want to talk a little bit about a concept that is really gaining awareness and is something that is being published on a little bit more. It's a relatively novel concept in oncology, which is this whole idea of treatment burden, which is really the work of being the patient. The treatment burden encompasses a number of different domains. It encompasses the experience of going through the side effects and adverse events that are associated with treatments, but it also incorporates concepts such as financial toxicity, the impact of the disease on a patient's capacity to work and continue to do the things that they love to do. It impacts their time commitment and the amount of time that they dedicate towards being a patient and going through treatment and working as a survivor, the distress that the disease causes, and then, of course, the impact on the people around them. And I think that the other kind of co-concept that is really rising up is this idea of resilience, which is really how someone can maintain their function psychologically, physically, and physiologically in the face of critical stressors, such as the diagnosis of cancer and the treatment. One of the concepts that we've been spending a lot of time thinking about in our research group at the Hutch is this whole idea of how can we kind of maximize and optimize and bolster resilience. And we all know that as we age, unfortunately, there is some degree of decline that is expected both physiologically and psychologically. However, when there's the stress of a diagnosis of cancer, that pathway or trajectory accelerates considerably. And then the degree to which the downward trend is modified really seems to be determined by the inner sort of capacity of patients and that inner resilience as one of the sort of overarching themes that can modify that. One of the questions we've been asking is, can we intervene earlier to bolster resilience and perhaps modify that trajectory and help get people back towards sort of what would have been their baseline slope? In the next hour, we're going to talk about how we can think about mitigating treatment burden and also increase resilience to improve overall health and wellness and quality of life during treatment and survivorship, specifically in kidney cancer. And we're going to take a tack of exploring some fairly novel arenas. We're going to think about complementary and alternative therapies and how those can be leveraged. We'll look at nutrition and wellness-based practices, cognitive support, and then have some really detailed discussions around exercise. And I want to introduce my incredible panel who's working with me today. Dr. Viraj Master needs no introduction, professor of urology at the Winship Cancer Institute and director of integrative oncology, is going to kick it off with a high-level overview of how integrative oncology can be leveraged in kidney cancer management. Dr. Anna Bausum is going to really get into nutrition and wellness-based practices and how those lifestyle medicine type approaches can improve the quality of life of our patients. Dr. Hannah Hunter is going to explore exercise as medicine, and I'm really excited for you to hear what she has to say. And Dr. David Shepard is a clinical neuropsychologist who we're lucky to work with at the Hutch. Unfortunately, he had a family emergency, so he sent some slides, and I'll do my best to present them and try to talk a little bit about how we can bolster cognitive resilience in our patients. So without further ado, let's have Dr. Master to the stage.
Thank you very much to the organizing committee, and particularly Dr. Sutka, for the imagination putting this session together. I've certainly enjoyed this meeting already and learned so much from all my friends and colleagues here. I'm speaking really in my capacity as the founding director of integrative oncology and survivorship at Emory, and we'll discuss two different broad concepts: the importance of integrative oncology to patients and physicians, and then really talk about the high-level overview of data-supported integrative oncology interventions that are part of recent ASCO guidelines in the last couple of years. So what is integrative oncology? There are those in the audience who definitely know this, but integrative oncology is not alternative medicine. Alternative medicine is when the patient is choosing non-conventional Western medicines in the place of Western medicine. Here, this nice paper from JNCI really helped to define what is integrative oncology. It's evidence-based use of complementary therapies in conjunction with conventional therapies, hopefully to maximize effect and decrease symptomatology. How many patients are embracing the use of integrative or complementary therapies? Really a huge amount, and the more you ask, the more you'll find. This is the largest study that is a little dated, 2017 from the CDC. 58% of patients report the use of natural therapies after diagnosis, and likely this is vastly underreported. And more importantly, 66% of oncologists say they avoid the topic, this topic when discussing with patients due to lack of training. This is a big money issue in America. This study estimated that between $30 to $60 billion are spent by patients out of pocket on complementary health approaches. This is likely, again, an underrepresentation. And the reality is that some of these therapies may work and some may not, but the patient is still taking them because they don't know enough to talk to their physicians about it, and their physicians may not be talking to them about it. And worse still, some therapies may be getting in the way of conventional therapies that are being prescribed by their physicians. At Emory, before launching our integrative oncology and survivorship service, we did a needs assessment, published a couple of years ago, and the biggest needs perceived by both patients as well as physicians in both the active phase of treatment and the survivorship phase of treatment were acupuncture, supplement wellness education, and massage therapy. My distinguished panel is going to go over some of the details, and I'm really going to talk about some of the high-level issues. Now, we started in January of 22, and you can see over here that in 2.5 years, we've completed more than 9,500 patient encounters. This is a reflection of just how much patients are thirsting for complementary approaches, whether it's our acupuncture service or our integrative medical oncology consultation service over here. So again, I said we need to be thinking about data. The Society for Integrative Oncology collaborated with ASCO in the formulation of 5 different guidelines, 3 of which have been published in the last couple of years. I've been fortunate enough to be part of this effort, and I must say, having written guidelines before, I was really impressed by the level of methodological rigor that was involved in these ASCO-SIO joint guidelines. The first one was on pain. This is a busy slide, as are the next 2. They're at a glance, so you find them on the ASCO website. But I wanted to point out to you that acupuncture for general cancer pain has significant evidence quality behind it, and an ASCO-rated strength of recommendation is moderate, which is pretty good, actually, especially given how small some of the studies are. So I would say those of you in the room, do tell your patients that for pain, acupuncture can be extremely helpful. Depression and anxiety are prevalent, almost endemic amongst patients with cancer. And it is amazing how particularly mindfulness-based interventions like MBCR, MBSR, which are available to be done virtually, as well as yoga can be prescribed to patients, or patients can participate in these, both for anxiety and depression, both during active phase of treatment, as well as post-treatment, again with a moderate level strength of recommendation. And then finally, the 3rd guideline, which just came out a few months ago, which was management of fatigue in adult survivors of cancer. Here, and again, there's, I think, others on the panel will cover this in greater detail, but exercise, both aerobic as well as resistance, and cognitive behavioral therapy are to be recommended. Now, the guideline went on to say what shouldn't be done. And what shouldn't be done is prescription of wakefulness agents to try to mitigate fatigue. The guideline was quite specific about that, so I think that's something to take away. Now, there is a growing body of evidence that does support things like acupuncture, so it is not just a arcane concept that has no bearing in neuroanatomy. Actually, this nice paper from Nature really went on to show that the stimulation of the ST36 acupuncture, which Anna will touch upon, the most commonly used acupoint both for clinical care as well as for research, results in ProCAR2 expressing sensory neurons directly communicating in this particular rodent model in this Nature paper with NTS, feeding efferently back via the vagus nerve to the adrenal, releasing catecholamines and decreased inflammation. So there's a real mechanistic basis to how acupuncture is working. Now I'm going to go on in the last few slides to talk about something practical that I didn't know and what you can do for your patients. This unpublished data is from Emory, over 1,000 patients who are going to have operations for stage 3 or stage 4 kidney cancer. And we were looking at the level of malnutrition via laboratory measurements. This is just looking at albumin divided into 4 more, 3.5 to 4. And close to 40% of patients are malnourished. These are patients who we're taking to the operating room. And in fact, almost 1 in 5 are remarkably malnourished with an albumin of less than 3. So is there something that we can do about this? And the answer is yes, immunonutrition. There's a lot of papers that have been coming out in the last several years about immunonutrition, usually involving omega-3s, glutamine, arginine, and branched-chain amino acid. This nice paper out of Kansas University went on to show that just 5 days of taking a commercial immunonutrition product twice a day was sufficient in this randomized pilot study to reduce wound infections and actually change Th1 to Th2 balance in this study over here. So I think there's something behind this, and there's many more papers that I could discuss about this as well, just 5 days. Not all of our patients, especially not where I practice in the South, can afford $10 immune nutrition shakes marketed by companies. You and your patients can have a homemade recipe. This is one that my team put together on a webpage, frailpatient.com, that contains these necessary constituents and is fairly inexpensive. Ingredients like peanuts, walnuts, Greek yogurt, etc. This complicated table on the right shows how much omega-3s, arginine, glutamine, etc. patients are getting. It's really easy for them to do, and it increases self-efficacy by the patient. So, in terms of take-home messages, what does this mean for practice on Monday? I'd say the ASCO-SIO guidelines on pain, anxiety, and depression and fatigue can be readily mined, and it is practical, easy to do things that can be done in the community, yoga, acupuncture, etc. And then some have integrative oncology programs in the medical center, I know. And then finally, RCC patients, especially advanced stage patients who are often malnourished, can make these homemade immunonutrition shakes, smoothies by themselves. So thank you for your time today, and delighted to be here.
Good morning. My name is Dr. Anna Bossum. I'm a naturopathic doctor at Winship Cancer Institute at Emory University, and I interface with patients related to integrative oncology, specifically its adjuncts to their care. Today, I'm here to highlight a couple of practical, cost-effective, and feasible takeaways to encourage patients who maybe are more limited in the access they have to acupuncture or the different modalities to integrative medicine, but easy to implement and walk away with. Some of them are lifestyle via nutrition, acupressure, and then importantly, some must-not misses and what to avoid. It's important. I notice that my patients really respond well when I say, we're looking for you to hold this for this amount of time for XYZ reasons. People are really, really receptive to that information because this combination of what they're maybe trying to do on their own at home, plus the guidance they can receive with consultations through me, gives them this agency of participating in their care that people enjoy and really see benefit with. Getting us started here, people ask me, what diet should I eat? And often the label of an anti-inflammatory or modified Mediterranean diet doesn't mean anything concrete to patients. Important, I highlight increase your omega-3 fatty acid intake, especially via fish or marine-based sources. And the reason being higher seafood intake and the omega-3s from that seafood were found on pooled analysis of over 25,000 patients to be significantly associated with lower risk of incidence of chronic kidney disease. This was not a benefit found in the plant-derived omega-3, such as alpha-linoleic acid. It was really more concentrated with the omega-3 intake, EPA and DHA of marine sources, and dually can help with the not only managing toxicities from treatments, but reduction in symptoms. 2 grams of omega-3 a day improve on preventing cachexia, reduce fatigue, brain fog, and even can reduce joint pain from patients either with cancer-related pains or just arthritic conditions they had as a kind of medical history item before a cancer diagnosis. A second hack: if exercise isn't very available due to either deconditioning or pain limiting their range of motion, I encourage people to do habits for insulin sensitivity, because research shows concomitant diseases like diabetes, insulin resistance, and lipid disorders may influence the prognosis and can significantly impact overall survival in renal cell carcinomas. And research shows that as little as 2 to up to 10 minutes of movement after a mealtime can help improve better blood sugar balance without even changing any of the food on their plate. So I encourage people seated heel raises, that 2 to 10 minutes, even maybe before they get up from their dinner table, can help support with improved insulin sensitivity over time. All right, now moving into habits that moderate the mind. We know not everyone's going to go out and practice meditation, or maybe breathing exercises are less accessible, but this is important to think about. It's important for every patient, no matter the treatment, but especially during active cancer treatments or around the time of surgery, as chronic stress, both from living kind of our everyday life as well as the diagnosis and the treatments, contributes to increased inflammation, and that can suppress the immune system. Patients with clinically significant anxiety more likely to have higher needs for opioids throughout the kind of post-operative periods or throughout their treatment. So kind of this intervention and making a meaningful impact on anxiety can be important. I encourage people to really lean into acupressure here. Here are 3 common points for acupressure. You can type any of these into Google and find a lot of demonstration videos how to. And importantly, this can be done for 1 point and help reduce anxiety, or any combination of the 3, and does not have to be administered bilaterally left to right for these hand points. If one side is accessible and the other isn't, totally okay. So important, how to do acupressure. It can be self-administered by the patient or a caregiver. So this is where family members can also participate actively in someone's care and symptom reduction. It's with the pads of the finger, a firm massage is either intermittently given with pressure, or this round circular motion, as if you have a grain of sand in between the pads of your fingers, should produce a light discomfort, but avoid being frankly painful. And you want to avoid applying acupressure over healing surgical incisions, open wounds, or rashes, or other medical devices maybe that are found under the skin. Is acupressure good for fatigue? Yes. In this NIH-funded RCT, acupressure in both a stimulating and a relaxing fashion significantly decreased fatigue, and that lasted after even the intervention, if you will, subsided. 6 weeks of acupressure and then this washout, especially people with the stimulating acupressure intervention, additionally found an improvement in the quality of life and an improvement in the quality of their sleep. So even without having to make regular visits to an acupuncturist, acupressure can be more and more accessible in daily administration for patients or as needed. So for pain, I encourage people, whether it's cancer-related pain or just they're seeking to take less of the opioids or prescription pain medicines, but have better control of their pain. This is a safe and effective way to, both for chronic and acute pain needs, offer them an intervention. The pains are this. This research comes from the postoperative period, where the acupressure to a point in between your index finger and thumb, called Li4, or a point on your ear called Shenmen, statistically decreased the analgesic needs via opioids and improved on patients' self-reported pain levels in the postoperative period after a major abdominal surgery. Natural products. I often get asked, can I take CBD? And there's problems with products that are just available over the counter or bought on Amazon, specifically with CBD, especially the high doses needed for moderating pain over long periods of time. LFTs can creep up. Here is an alternative that's both helpful for the adjunct for treating inflammatory and neuropathic pain. The picture here is a little bit obscuring the rest of the slides, but PEA, it operates on the same receptors, the endocannabinoid system, as CBD and THC, but is better at dosing no drug-herb interactions, and this 400 to 600 milligrams PO twice a day, helpful as an adjunct for pain relief with no drug-herb interactions and none of the safety issues of higher liver enzymes with CBD. All right, nausea, vomiting, constipation, we'll wrap it up. Nausea, vomiting can be supported with the same acupressure point, PC6, that was also helpful for relieving anxiety. It's found 3 finger breadths below the wrist crease in between the tendons and can be helpful either via people wearing a C-band, acupuncture, electroacupuncture to this point, or used as needed. The most common, if you will, error I see patients make here is they'll wear these C-bands right below their wrist crease. It needs to be placed 3 finger breadths above for that antiemetic, anti-nausea benefit. ST36, Dr. Barrage Master had already alluded to it, the biggest and most well-researched acupressure point in the body, so it's large and easy to find. It's located on the lateral aspect below the knee, kind of at the top of the head of the fibula. This is where demonstration videos really become handy. It is helpful for the relief of fatigue. It's part of that 10-minute daily routine for acupressure in relief of fatigue symptoms, but can also promote recovery time of postoperative ileus and improve on 24-hour colon transit time in the postoperative period. So this is something, even as people are recovering in their hospital bed, caregivers can massage this point below the knee for the benefit of their recovery. Some things to be aware of, right? Working with someone whose subject matter expertise is this, to really talk to what's the intended dosing benefit we're looking, what's the interaction we want to avoid, what to save your money on, so skip buying on Amazon, monitoring kind of for the use of physician-grade products, and they're out there, it's just hard to find, and as a patient navigating this world alone through what products are worth their money, where should they save their money, can be a really big burden. So speaking to a couple of avoids, potential blood clotting issues with ginkgo, high-dose vitamin C, garlic, cayenne. Vitamin E, often even given prescription doses for preventing radiation fibrosis. So this is something to screen patients for. Avoid kava and St. John's wort as potential interference with anesthesia. And then some avoids for your immunotherapies, either kind of your pembrolizumab or targeted therapies, anything that pokes at the immune system, I ask people to avoid. This is an area where there's not enough research done, so avoid things like medicinal mushrooms such as turkey tail, probiotics, Echinacea astragalus, especially common for patients to use around cold and flu seasons, and then things that move liver enzymes, and here are a couple of examples. So putting it all together, there are small hacks and stacks patients can implement for managing toxicities, reducing symptoms that are cost-effective and supportive, and can be really added in as part of their everyday life. That doesn't cost them much more than a couple minutes a day, and being intentional about this integration can be very helpful for their their agency in this process and reducing symptoms. So consider encouraging patients to increase omega-3s, add in these hacks and stacks for insulin sensitivity via heel raises after meals, and really screen patients for supplement use and have that conversation that's very transparent about where is there some evidence for benefit and where should they avoid things because of potential harm or contraindications. And with that being said, turn it over.
I think that's probably one of the most common questions we get at the end of a consultation is, doctor, what should I be eating and what supplements can I take? It's all about, a lot of what we're talking about here is sort of reassigning the locus of control in the patient encounter and giving patients some clearly pragmatic, actionable sort of takeaways that they can integrate in their lives to actually start to move the needle, in addition to the sort of the conventional therapies that we often discuss as surgeons and physicians. So I'm going to present now for Dr. Shepard, and the goal of this next talk is really to think about how we can manage sleep, fatigue, and distress, and specifically taking this cognitive neuroscience perspective. So our objective is to identify effects of distress, fatigue, and disrupted sleep on how the brain functions and our cognitive ability to process and interact and work in the world around us as patients are going through treatment for kidney cancer. And we'll review some evidence-based strategies for managing these key factors. It goes without saying that a patient who's dealing with a new diagnosis of kidney cancer or any cancer is going to encounter many different factors that will impact cognition. Indeed, the disease-specific characteristics, such as the pain caused by the disease, but then all of the treatments that patients are asked to undergo, including medications that impact the immune system, the hormones, patients' hormones, cytotoxic chemotherapies and immunotherapies, all impact cognitive functioning, as does the mental health ramifications of the diagnosis, the fatigue that can elicit, and the stress and anxiety of going through what is a life-changing diagnosis. And all of these can impact distress, they can increase fatigue and disrupt sleep. Kidney cancer specifically is a risk factor for incident cognitive dysfunction in older adults, and you can see the cumulative incident graph in patients comparing matched control patients against a cohort of patients with metastatic renal cell carcinoma. Oral anti-cancer agents and nephrectomy are not specifically noted to increase the risk. It seems to be more associated with the overall experience of the diagnosis based on what the limited literature in this space tells us. There are also some shared risk factors in patients with kidney cancer for cognitive dysfunction, including some of the paraneoplastic syndromes that are very common among patients with kidney cancer that can impact things like calcemia levels, and obviously renal dysfunction, which is important both in patients with the incident diagnosis and patients who have subsequently undergone nephrectomy and further therapy. And then, of course, as we'll talk a little bit more about, the distress of the diagnosis and disruption in sleep and fatigue can impact cognitive functioning substantially. We know that cancer diagnosis and cancer treatments are substantially increased with an increased risk of physiologic stress, which subsequently can impair ability to achieve a good rest and for patients to function properly. And the mental health impacts of a diagnosis of cancer cannot be understated. I think that one of the researchers whose body of work I look to most on this is Zach Clausen, who's done has published a number of different papers using population-based literature that demonstrate the substantial increased utilization of mental health resources among patients with newly diagnosed cancers. In terms of how we can combat the cognitive function deficits that we see in patients with newly diagnosed kidney cancer and patients undergoing treatment for kidney cancer, Dr. Shepard tends to separate these strategies into two main groups. The first are restorative strategies, and these are strategies you can think of really as training the brain to undergo the stress of treatment and management of the cancer. There's been a lot of interest with the rise of digital health applications to try to see how we can basically try to minimize the risk of postoperative delirium and postoperative cognitive deficits related to general anesthesia, as well as to the therapy, to the therapies that patients with kidney cancer undergo. One of the most commonly cited clinical trials in this space was the Neurobics trial. This was a randomized controlled trial of 268 patients undergoing non-cardiac surgery who were instructed to utilize a iPad or tablet-based Lumosity application for 10 hours in the week prior to their surgery. And basically, although very few of the patients actually accomplished, who were randomized to the intervention group, actually completed all 10 hours of the intervention, they noted the researchers noted that even minimal compliance with these compensatory training strategies were associated with decreased risk of postoperative delirium. And if you're interested in reading more about this, one of my anesthesia colleagues, Dr. Itai Bentov, just recently published a very nice review of some of these compensatory restorative cognitive strategies that can be utilized specifically for this objective. The other strategy is more of a compensatory strategy that specifically looks at trying to minimize the interference of cognitive difficulties in daily life. And here, Dr. Shepard talks to his patients about strategies that basically can unload the brain. So he talks about things like setting alarms to remember to take medications, placing your keys and your sort of key tools that you need every day in the same place, so you don't have to think about where you've left them. Basically, there's so much stress on the brain as someone is going through treatment for cancer. The idea is to minimize the amount of additional cognitive processing that's necessary to get through life. And what the data seems to support is that these compensation strategies actually improve real-world cognitive function even more effectively than the training the brain strategies. And Dr. Shepard uses this metaphor. He says your brain is kind of like a cup, and the water is the information that your brain is expected to manage on a daily basis. Ice cubes basically can function like distractors. These are fatigue, pain, poor sleep, and worry, commonly exacerbated with the diagnosis of cancer and the treatments. And those distractors really take up cognitive energy and displace the ability of your brain to function normal, your brain's cognitive normal processing. So the idea is to unload the brain, and in doing so, hopefully facilitate improved cognitive functioning. There's been a key theme in all of the talks that you've heard so far, and you're about to hear a really excellent talk on how exercise is a critical tool that we can leverage to improve and mitigate some of this cognitive dysfunction that occurs with those distractors. And Dr. Hunter is going to really highlight her pragmatic approach to optimizing how patients can integrate increased physical activity into their lives while going through treatment for cancer. But key points are that consistency is key. It's also, and there's very good evidence that consistent physical activity is significantly associated with an improvement in cognitive resilience in older adults. And aerobic activity also has substantial benefits for both short-term and long-term memory, as well as executive functioning. But it has to be done in the context of someone who's going through a lot of other physiologic stressors. And so it's important to think about pacing and making sure that if activity is integrated, it's integrated in a manner that can be sustained throughout treatment and then survivorship. Sleep is critical. In order for our brains to work well, they have to be rested, but unfortunately a lot of the stresses that we've already discussed that are associated with a new diagnosis of cancer can impact our ability to sleep well. Dr. Shepard specifically counsels patients a lot about sleep hygiene, and he makes a couple of key points, and some of the takeaways he wanted me to share with you are that he tells patients that sleep is like a hunger. So although we may be tired during the day and napping may seem especially enticing, eating those snacks before a big meal can impact appetite. And so he specifically counsels patients to try to minimize napping during the day with the goal of obtaining really good quality, high quality sleep at night. Consistency in scheduling is also important, and then minimizing potential caffeine and other sort of wakefulness-based intake that could impact the body's ability to achieve good, restful sleep. And then I think the other big part is that comes up here is the distress and anxiety that's very common with a diagnosis of cancer can impact ability to fall asleep. And so he strategizes with patients around sort of healthy falling asleep, and if you're lying in bed and your brain is going a million miles a minute, he says that's a moment when you get up, go do something else that is restful, and try to go back to sleep a little bit later. Certainly behavioral stress management is critical, and there's some key strategies that can include physical activity, but also mindfulness-based practices such as diaphragmatic breathing and meditation. Yoga has been mentioned a couple of times today as a really critical adjunct to manage mood disturbances associated with a cancer diagnosis. And obviously integrating the adjunctive supportive services of psychotherapy can be very helpful in this space. And so in terms of just overall takeaways, I think a couple of the key points that we wanted to hammer home here are that obviously diagnoses of new cancers are associated with a number of different mental health and cognitive functioning impacts. And the distress of a diagnosis, the fatigue associated with treatment, as well as with the anxiety that comes with the diagnosis, can disrupt sleep, and you get into a fairly aggressive cycle that can result in further fatigue, further distress, and disrupted cognitive functioning that can make it hard to really maintain quality of life through treatment and survivorship. It's critical to help patients find behavioral strategies that are pragmatic, that they can integrate into their day-to-day living, that include things such as compensation strategies, diaphragmatic breathing, and consistent physical activity, as well as sleep hygiene, to help manage this distress and to improve fatigue and maximize sleep and restfulness, to impact cognitive functioning and maximize that through treatment. And with that, I'd like to thank you, and we'll pass the mic to Dr. Hunter.
I'm so excited to share a little bit about physical activity and exercise. I actually made my way here from a rehab conference and wanted to share with the group that our patients with cancer is our growing or fastest and largest patient population in the rehab space and sports medicine world. We know how to rehab patients after a stroke. We know how to help athletes run faster, jump higher, improve that muscle quality and muscle mass, but we haven't translated that well in cancer survivors. But hopefully that's our next research frontier. This talk is really about physical resilience, or the idea of resilience, which in the physics definition is an ability of an elastic material such as rubber to absorb energy and release that energy as it springs back to its original shape. The kind of analogy I use throughout this talk is the idea of going on a hike. And in that idea, our goal is not to exhaust our entire gas tank of energy on the hike, but to figure out a way to pace and get through the hike while enjoying the entire experience. This idea of building physical resilience is a way that patients can take a proactive approach to their cancer journey, and is really the basis behind this idea of prehabilitation, which is the process of improving the functional capacity of a patient prior to a surgical procedure so that a patient can withstand post-op inactivity and treatment-related decline, AKA boost up resilience. And this is not just specific to cancer, but even prior to the idea of prehab in the cancer setting, we don't wait till, in the setting of a joint replacement, let's say a knee replacement, we're not going to wait till someone can't walk on that knee and has lost all their muscle mass to have them be an ideal orthopedic candidate. We want them to go to physical therapy before their joint replacement, know what exercises to do so that they can bounce back quicker. And this idea of prehab has definitely been growing in the past few years. If you can see this kind of robust exponential increase in prehab articles. And this is the graph that Dr. Sutka showed earlier. And our goal with prehab is that though we know that muscle mass and functional decline occurs with aging, if we can alter that slope of decline so that patients can get closer to that of healthy normal aging versus the decline experienced due to cancer, that's awesome. So I'll talk a little bit about prehab, pacing, and perspective in the setting of physical activity and our need to make this more personalized and pragmatic for patients. So if we think about this woman who's about to go on this hike, she may not be prepared for her cancer journey. It's hard to physically be prepared, but she's cross-trained for this hike. She's never done this hike before, let's say, but she's cross-trained, she's hiked before, she knows the route, and in that sense, she's prepared. And her prehab is having these lived experiences, whether they're physical or psychological, to know that she can take on the challenges of the hike. And before I talk about the specifics of physical activity, I wanted to bring up this idea of bed rest, because it wasn't that long ago that we were actually prescribing bed rest rather than physical activity for patients. And it wasn't until the baby boom, post-World War II, where labor and delivery units were full of women, and they ran out of beds, and they realized that the women who were not put on bed rest did a lot better. There was a lower rate of blood clots. They were able to go home quicker and less complications related to delivery, which kind of spurred on this interest in later decades on studying the benefits of physical activity and exercise in healthcare, and eventually led to guidelines recommending, this is probably somewhat obvious to everyone in the room that we should be promoting aerobic and resistance exercise to patients during treatment, not only because it improves bone health or muscle strength, but the idea of exercise and physical activity ripples into many domains related to quality of life, whether it's fatigue, better sleep, decreasing the risk of falls, and most importantly, helping our patients do things that they want to do. And this culminated with the American College of Sports Medicine having a roundtable of experts concluding that we should be recommending a certain amount of exercise for patients during and after cancer treatment. And that dose was 150 minutes of moderate intensity activity and 2 to 3 sessions of resistance exercise per week. However, I would argue or advocate that we can't just kind of slap that prescription on every patient that we see. It has to be personalized, especially if someone's experiencing nausea, they're cachectic, they're experiencing severe fatigue. It's nearly impossible for the most motivated person to say, I'm just going to go do 150 minutes of moderate intensity exercise, and they don't know what it looks like. And so our job in the rehab space is to create this exercise prescription that's personalized and pragmatic. And when we talk about an exercise prescription, in the same way that we prescribe exercise, it should have a specific type, a dose. Patients should be counseled on side effects, and they should know what they should be not only doing, but what benefits they should be reaping from the exercise that they do. Whether it's strength training, whether it's going for a walk, figuring out how to make that doable for our patients. And part of that is pacing. So if we go back to this analogy of this hiker who's going on the hike, she's not going to start sprinting up her 5-mile hike. She's going to figure out a pace that she knows she can get up to the summit and back down, but also leaving enough gas in the tank so that she can drive home and maybe, I don't know, make dinner or do a load of laundry. And pacing is often the biggest challenge for pacing for physical activity during and after treatment. And when I counsel patients on this idea of pacing, we talk about it as being energy-wise. It's not draining your entire gas tank to do an exercise routine and not leaving any gas in the tank to spend time with family or do household chores. It's a pre-planned strategy of reaping the benefit from exercise to actually energize your day rather than feeling more fatigued, nauseous, or other side effects of treatment. In terms of a quality of life perspective, it's conserving energy for activities that patients want to do. And what's critical is finding that baseline that's sustainable. We're not necessarily counseling our patients to be weekend warriors of doing that 1-hour yoga routine, but finding an exercise routine that's doable on a good day and a crummy day. And the goal of pacing is to avoid this seesawing between overexertion and rest, which a lot of times our most motivated patients experience. They're used to doing a lot of physical activity, and they try to get back to their pre-cancer baseline, but it's really about finding a baseline in the current moment and then slowly increasing from there. We typically say 10% increases in physical activity a week as a goal. Less is totally doable, but not going past that to avoid the seesawing between overexertion and rest, because that's often when injuries can happen. Pacing is also about finding a routine of physical activity that's enjoyable, and our research in exercise has shown that patients are more likely to do it if they pair it with activities they enjoy, whether it's listening to music, an audiobook, or meals. I love the idea of exercise snacks. I tell patients to do sit-to-stands every time they eat a meal. We're often asking patients to eat every 2 to 3 hours, so if they do 5 sit-to-stands every 2 to 3 hours when they're having a snack, sometimes they've done like 20 to 25 squats, and that's wonderful. There's this emerging field of digital health research, but also the use of trackers for help patients keep a diary of their physical activity, and social support is also key. So going on a walk with people that they like, their dog, can be motivating. So going back to this idea of pacing and exercise snacks, When patients are motivated, like they've gone on a walk, let's say it's 10 minutes long, 20 minutes is actually double the amount of exertion and activity. So we want them to have achievable or pragmatic goals. Even in our exercise study with Dr. Sutka, we talk about, like, should we increase our step count for patients by 3% a week or 4% a week? Like, those are pragmatic goals, not doubling the amount of physical activity per week, because again, that's not sustainable. And the last things I'll talk about is perspective. When patients are on this cancer journey, especially trying to incorporate physical activity on the journey, it's not about just getting things done, getting to the summit or finishing the hike. It's really about finding a way to make it pragmatic and enjoyable for patients and to also reap that benefit of exercise. I love this quote by Maya Angelou that says, "I can be changed by what happens to me, but I refuse to be reduced by it." We hear patients often ask, like, when am I going to get to my baseline, pre-cancer baseline? But a lot of the counseling our rehab team provides is about finding what works now and moving forward, finding your baseline to return to tennis as a cancer survivor, not return to the tennis player that you were prior to your diagnosis. But I think this mentality of being able to find that finding that baseline pace and move forward is really key to reaping those benefits of physical activity. And the one thing I'll end with is future directions with research. We know that exercise is beneficial to everyone for heart health, brain health, cognitive health, physical health, but we don't know how to do it well yet in a pragmatic way. AI, digital health is helping us understand what patients do on a daily basis with remote patient monitoring and helping establish personalized goals as well as decision support tools. And we know this works even in our athletes. They exercise, they eat well, but they all don't do the same thing. They do what works for them to, again, run faster, jump higher. And this approach needs to be personalized in the same way it is for our athletes, for our cancer patients, with a team approach and a tailored program. And it's got to be doable.
Well, thank you to our incredible panel. Just to wrap up, so where we started this hour talking about the fact that we have two critical problems in oncology in general, but specifically we're talking today about kidney cancer. We need to reduce treatment burden in patients. We need to reduce the work of being a patient, and we need to bolster resilience across all the different domains, physical, cognitive, emotional. And we need to help patients basically get stronger so that we can optimize quality of life through care and after. I think our incredible panelists today have offered us some key and pragmatic solutions that we can all take home and even think about integrating into our practice on Monday. And we'd all be happy to show you some of the resources that we use on a daily basis to help support our patients when they come see us. I want to just highlight a study that Dr. Hunter and I are engaged in right now that is specifically trying to see how we can really take the science of exercise integration into in support of care pathways and make it pragmatic. One of the key limitations of the prehab quote-unquote literature to date is that a lot of the studies that have been done are of interventions that really are not feasible or scalable in any way, shape, or form and actually add to the treatment burden of patients. I can't ask my patients who are already who just underwent a cable thrombectomy and large nephrectomy, who now are going through a year of adjuvant pembrolizumab. I can't ask them to come to the gym 3 times a week so that I can watch them, or my team can watch them do exercises, especially since a lot of my patients are coming from Eastern Washington or even from Alaska. So the whole question here is how can we bring this and how can we actually do this in real time? How can we not add to financial toxicity? How can we not add to treatment toxicity? So this is the University of Washington Get Moving trial. Now this is a bladder cancer trial, but it is I would say a research approach that we are looking to scale across disease spaces. This is a phase 1/2 randomized controlled trial of home-based prehabilitation with a digital health application called ExerciseRx in patients with localized urothelial carcinoma. Dr. Cindy Lin is our co-collaborator on this case. She is also a sports medicine physician who, with the engineering team at UW, developed a program called ExerciseRx, which links with our electronic health record This is a patient-facing app that can be run on any smart device that delivers a personalized exercise prescription that's designed for patients by Dr. Hunter, and then through which we can actually track adherence in a privacy-protecting fashion and monitor patients' progress as they're doing their exercises while they're getting chemotherapy in the post-operative recovery period through, in our case, EPIC. And again, this is what the app looks like. You can see here one of the prescriptions being demonstrated. We have essentially a menu of exercises that are each delivered at variable intensities that can be utilized by patients who, for example, require an assistance, a mobility assistance device. So each activity Dr. Hunter has designed to be done depending on the physical ability of the patient to be appropriately challenging, but not so challenging that they would be potentially dangerous. And the additional intervention here is also a modified step count that increases in intensity as patients hit their thresholds. And there are co-primary endpoints here. I'll just show you the study schema. This is for adult patients with localized bladder cancer who are randomized to a 4-time-a-week, about 20 to 30-minute pragmatic home-based personalized exercise prescription. The goal of these exercises is not to help patients flip tires or run a faster mile, but really to actually increase core strength and balance and gait speed to facilitate preparation for a major abdominal surgery and hopefully accelerate recovery following that. The standard of care, the control arm, is patients actually receive the Moving Through Cancer recommendations from the American College of Sports Medicine, and those are those recommendations that Dr. Hunter highlighted in her last talk. And again, we're looking here at not only feasibility, but also the ability to affect change in a short physical assessment called the Short Physical Performance Battery. So this is one way that we're tackling this problem. But I think one of the key take-homes from this whole session that I hope you will all bring home to your home institutions is that supportive care options are really helpful in all patients. These are not just things that we should be affecting in patients who have baseline frailty or patients who are older. Our younger patients are patients who have potentially other vulnerabilities that if we're not looking for them, we're not going to identify. Everyone has the ability, or everyone has sort of targeted, I would say, vulnerabilities that we can improve to bolster their resilience, both physiologically, mentally, and cognitively. And so the hope here today is that we have shared with you some pragmatic supportive care solutions to facilitate patient-centric care, to reassign the locus of control and help patients take agency in their treatment, to potentially mitigate treatment-associated toxicity with complementary therapies in addition to the conventional therapies that we utilize in kidney cancer care. We've really focused on what we think are some pragmatic approaches, because again, we don't want to add to treatment toxicity and financial toxicity here. And the whole goal is to bolster resilience, to improve quality of life. I think the most important thing here is that at the end of the day, we do actually have to ask patients what they need, because some patients are really going to be struggling from a mental health perspective. Some patients are going to kind of report to you that they have that fog associated with either IO therapy or post-operative short-term memory loss. These are all critical problems that if a patient brings them up, we do have some solutions. And we've got great resources in our partners in our cancer centers that we can leverage. But I think sometimes we underutilize these resources, and this is a great opportunity to kind of build out the team to bolster resilience development. So with that, I want to thank you all very much for your attention, and we'd love to take any questions. I've got some incredible, I would say, brain power from our supportive care field here, so we'd love to hear what you have to say.
Hi, it's wonderful to have this session. I think it really emphasizes the patient-centered approach and providing holistic care. So I just wanted to share an experience at UT Southwestern. So what we have done, maybe about 7, 8, or 9 years ago, we launched a patient advocacy and volunteer program. So we have patients who are routinely coming to clinic, and they share snacks with other patients and initiate conversation, and they are available to answer questions from other patients, to talk about clinical trials. And it's been extremely impactful. The patients themselves who are volunteering feel privileged to do it. In fact, we stopped it for COVID, and then we restarted. And after I met with the group of volunteers that picked up the baton after COVID, and just asking them how it was going, the consistent theme, they were thanking me for the opportunity that I gave them to volunteer in clinic, which obviously is backwards, right? We were very grateful for what they were doing. But it's had a tremendous impact in building community. I think both the volunteers and the people who feel their presence and their service, and they feel like they are cared for, they're becoming part of a community, it's had a lot of impact, so something to think about.
That sounds like an incredible program, and Sid, that kind of speaks a little bit to what you were talking about, just in terms of empowering patients to reach out, share stories, find community, and share their lived experiences.
Yeah, in fact, it was Sid's presentation that led me to share this, so thank you.
Thank you.
So, thank you. One of the biggest problems that we face with that is that we're asking for behavioral changes of long-term behaviors that we have all there. Having you as the experts there, how can we do that? How can we actually implement those behavioral changes, not only in our patients, but maybe in ourselves, when we don't have phase 3 data that are like, you have to do this and this in a structured way? Well, how do you motivate people to do those long-term sustainable changes?
I can start. In my experience, behavior is best changed in community. So this element of finding peers. At Winship, we run shared medical appointments for some of this because they'll adopt behavior changes and improve their quality of health and reduce symptoms in the group. And this data comes out of the Cleveland Clinic. In the group exceeds what the individual component can do alone. And then for building habits that give you longevity, people's confidence grows when they have small habits they can meet consistently. So this is why I start with people, this postprandial movement while you're still seated, 2 to 10 minutes of heel raises. When they check that box every day, it lends itself even psychologically to meeting the next step of this goal in scaling so that they're building on more and more strength, little by little, again and again, over time.
I'd also like to comment on this issue of community. So cancer is an extraordinary moment in the life of the patient and their families or loved ones. So they are often in a receptive state to changing things. If there are dietary changes that I'm advising patients to do, I will often look at the whole family and say, and all of you will support your loved one if you are all making these dietary changes. And for example, they have various variations on their smoothies that they all make and they share with me and so on. They bring them into clinic. So I would just say that it's, if you incorporate the idea that it's not just the patient, but their entire community, changes can be long-lasting. Thank you.
And I might just add, so Michael, to your point, there are a couple other kind of key, you asked about the providers changing their behavior. We need to ask patients about what they need and be sure that we are sort of thinking about nutrition and physical activity. I think it's hard in the space of a 15 to 30-minute visit where you'll have to convey an enormous amount of information, perhaps about surgical risk or new systemic therapies and sort of the overarching arc of how we're going to care for someone with a new diagnosis of kidney cancer, to then be like, okay, now let's get into the nutritional counseling and here's your physical activity prescription. So this is where we work as a team. This is another extension of multidisciplinary, personalized precision medicine. But I will tell you, so some key strategies that we've incorporated at the Hutch, and Hannah has been leading an effort in this, is really to actually improve referral pathways. So all of our patients have a basic frailty screening procedure that they go through as part of their entrance paperwork. If they screen positive for malnutrition or frailty, that automatically instigates a potential referral and option for those patients to be seen in nutrition and physical medicine rehab. I think that takes the work off of the the surgeon or the medical oncologist's workload and sort of ensures that that referral does get made. Now, one of the other issues there is resources, so we have to be thoughtful about that. But I think that that's one key way that we're just trying to streamline referral pathways and make it easier. The other key point about building positive habits with patients. We ran focus groups and did qualitative interviews with patients with bladder cancer in preparation for our Get Moving study to understand, basically do a needs assessment and ask what were the barriers to physical activity that they encountered having already gone through neoadjuvant chemotherapy and a radical cystectomy, and what were the key facilitators. And Viraj, Dr. Master has also published extensively on this in surgical oncology populations. One of the key points that was raised by patients was actually having their providers check in with them and hold them accountable to these positive lifestyle changes and encourage them was incredibly powerful. It was a very powerful motivator. So one of the strategies that we've incorporated in our trial is that Dr. Hunter and I can actually monitor adherence through the app, and we send the patients little pings throughout the week and say, hey, you're doing great. You just hit all of your thresholds for the week. Or it looks like you're struggling. Do you need help? Can we check in with you? And those are automated within our system, but they're very meaningful sort of touch points that can motivate patients. And we have a paper actually that will be coming out hopefully in the next couple months on barriers and facilitators to physical activity in the perioperative period that may hopefully provide some actionable commentary there.
Yeah, hi, Martin Voss, New York. Thanks for a great session. So super helpful, and I agree with Sarah. These are some of the most common questions we get in med-onc clinical. So now, a lot of the advice that you give and the efforts that you point to are, in the perioperative setting, getting a patient fit for surgery and helping them in the aftermath of an operation. It's kind of like training for a marathon and then sort of, doing the post-marathon training. But for us as GU oncologists, there are very different challenges. The chronicity that patients face is very different, and a lot of the lifestyle modifications that are needed, in my opinion, are very much mechanism-based in terms of on-target toxicities that we see with the treatments that we give. And I wonder if you have in your own practice guidance, and if there are resources you can point to that speak to the specific challenges that patients face if they're on one therapy rather than the other, right? So for instance, giving someone guidance to do 20,000 steps a day when they have grade 2 hand-foot syndrome is just not productive, right? It's going to make their toxicity worse. So are there things for TKI versus IO toxicities that you see in your practice as helpful? Are there resources that you can share for all of us to hand on to our patients? Thank you.
I'll share a little bit about in the physical function space, especially when patients are on long-term treatment, and particularly our older patients who are experiencing sarcopenia, and that's also setting in the setting of being on treatment, and we see that muscle wasting or muscle wasting syndromes over time. A lot of the functional goals I have, or exercise goals I have for patients are based on function, and that motivation is no longer like this upcoming surgery or advice that was given to me by my surgeon for these few weeks, but that long-term change is definitely more challenging. I think there are, when I see patients and are doing an assessment on balance or side effects of treatment, whether it's neuropathy or fatigue, the goal of the exercise prescription is to mitigate that, but also for patients to be motivated to be able to do something that's important to them. Because a lot of exercise is not just for building muscle mass, but I'll tell patients this is so that you can get off a toilet in a public space, or that you can get out of a car without assistance, or that you don't fall on your way going to the bathroom at night. And so I think personalizing those goals, aside from treatment, is also important, but also prescribing exercises that hopefully are mitigating potential toxicity from treatment is also key. So I think of it more so, maybe more toxicity oriented, more so than just treatment specific.
I think Dr. Voss brought up an excellent point. I would say that we, both in GU medical oncology likely, and certainly in surgery, minimize the mental health toll on patients. So I think that anxiety and depression is really endemic, actually, to many patients. And what you can do, whether they're having IO toxicity or TKI toxicity or a mixture of both, is to remember that gentle yoga is both a physical movement and also it can be helpful, very helpful, with the ASCO guideline in mind for anxiety and depression. Once the patient's mental health status is, their trajectory is modulated positively, they will be more able to engage in some of the other things that you want them to do. At our Comprehensive Cancer Center, we do have oncology yoga, and there's a variety of patients with a variety of different toxicities, whether they're radiation-induced toxicities, surgical-induced toxicities, or systemic therapy-induced toxicities, and the different yoga patterns are modulated for those patients. So I would say that that's the one thing I would take away from that. Probably my wife tells me I should do yoga more, but all of us probably could do yoga, and there's real scientific underpinnings of it. Thank you.
One other just follow-up point to that is just going back to how what I said when I was wrapping up. All of these interventions are really meant for everyone. We're talking about sort of lifestyle interventions to facilitate a healthier well-being and healthier lifestyle. So I will often engage patients, for example, with a 1 centimeter renal mass who I'm meeting for the first time that we're going to be planning on active surveillance. I will ask them about their physical activity and their nutrition, and we'll look for potentially modifiable vulnerabilities, because that's someone who maybe not today, but maybe in a couple of years, they might need to go through an abdominal surgery, or they might need to go through radiation or ablation. And that we can use the time between now and then to basically make them stronger. And I think that, to Dr. Master's point, the diagnosis of cancer is an eminently teachable moment. It's a moment when life changes irrevocably. And so this is an opportunity to improve quality of life overall. We know that moving more, eating a healthy diet, and focusing on things like mental health and cognitive functioning improve quality of life regardless of treatment stage and of disease stage and treatments that are being someone is going through. So I think it's an opportunity to really think about how can we empower patients to live well at any step, at any stage. But the key point that I hope has come across here is that it always has to be with a pragmatic lens. So just giving a blanket statement, you need to move 150 minutes a week, you need to do 10,000 steps a day, that is not appropriate. But if we do formal assessments of where patients are at, leverage our incredible colleagues in all of these supportive care disciplines who really have done the hard work of doing the science to evaluate strategies that work, we can hopefully move the needle for every patient across the span of the disease. Thank you all so much for your comments today. Thank you all for your engagement. I believe so.